All right, guys, let's talk about chronic kidney disease today. Now, yesterday we talked about acute kidney injury. And in acute kidney injury, we talked about pre-renal, intra-renal, or post-renal causes. And pre-renal, we talked about how you may have something like hemorrhage, severe hypotension, dehydration, or maybe a blood clot that was not allowing adequate blood flow to the kidney, and as a result the kidney would suffer some injury, hence the name acute kidney injury. Or maybe the patient was receiving something like vancomycin, gentamicin, maybe x-ray dye, iodine, and maybe that iodine, vancomycin, or gentamicin caused intra or inside of the kidney to become damaged. Or maybe there was some post-renal complication, maybe like a kidney stone in the ureters, maybe BPH, prostate CA. Well, in acute kidney injury, if we were to remove the cause early enough, then that would allow the kidney to heal, and you would have adequate renal function again. You would have waste products being able to be removed. You would have blood pressure being able to be regulated by getting rid of fluid or water. So you'd have adequate urine production. So in acute kidney injury, the injury was able to be reversed. In, however, chronic kidney disease, chronic renal failure, there is irreversible loss of kidney function, meaning the kidneys will no longer be able to work. They will no longer be able to get rid of waste products. They will no longer be able to produce urine. So you will have an accumulation of fluid leading to edema, leading to pulmonary edema, pulmonary effusions, causing cardiac complications. So that's just a little bit of an overview of what's going to be discussed in this lecture. But let's first look at some causes. There are two causes that you need to know for the Nclex exam. Number one being hypertension, and number two, diabetes. Now here we have a chronic disease. So again, hypertension and diabetes are chronic problems, chronic pathologies. Both of these resulting in nephron damage to the kidneys. And of course, we are talking about an irreversible kidney damage. So let's focus on some clinical manifestations, and I recommend you going back to our lecture on acute kidney injury. That will make this, I think, easier to understand. So let's jump into our clinical manifestations right away. Now again, I'm going to get you or hit you with the most basic information that you need to know for the Nclex exam. So I'm going to run through this very, very quickly, so please get out your pen and paper. Or if you're listening in the car, let's get started. Number one, you have to know that we are no longer to get rid of waste products. So we're going to have an increase in our BUN levels, we're going to have an increase in our creatinine levels. Another thing that you need to remember is that you will not be able to get rid of certain hormones, in this case insulin. Okay, and that again, that is due to that impaired renal function or loss of renal function. You will also have electrolyte imbalances. There will be changes in your sodium, your potassium, magnesium, calcium, phosphate levels. Again, because the kidney is unable to regulate those levels properly because you have lost that kidney function. And number five, you will have fluid accumulation or edema due to being unable to get rid of water. Now, along with this fluid accumulation and edema, you'll also have an increase in blood pressure. Okay, so number one, polyuria, eventually ending with anuria. So what do I mean here? Well, let's say that this patient is a diabetic patient. Now let's go back to some of the clinical manifestations of diabetes or some of the signs and symptoms. We talked about how a patient may suffer from polydipsia, polyphagia, and polyuria, so the patient is voiding constantly large amounts of urine production. Now, as the kidney becomes more and more damaged, that urine production will become less and less and less. Once we end up with renal failure, kidneys failing, well, then that patient will no longer be able to produce urine. And so therefore that patient will suffer from anuria, or zero urine output. Number 2, increase in BUN and creatinine levels. Now this increase in BUN will cause the patient to suffer from nausea and vomiting, from lethargy, from an altered mental status or changes in their mental status. And also the patient will end up suffering from headaches. Again, this all has to do to those increases in BUN levels. So number 4, hyperglycemia. Number 5, hyperinsulinemia. Now we talked about how your kidneys will no longer function, therefore you aren't able to get rid of certain hormones, insulin being one of them. So again, we will suffer from hyperinsulinemia. Now, because we suffer from hyperinsulinemia, this will also stimulate the production of triglycerides. So you will have an increase in your triglyceride levels, mainly an increase in your LDLs. I believe you're very low. So increase in your LDLs with a decrease in your HDLs. Now remember, your HDLs are your happy fats. They make your heart happy. It's the way that I remember them. So these are actually good for your heart. But in this hyperinsulinemia causing increased levels of triglycerides, you're actually going to have a decrease in your HDLs and an increase in your LDLs. Now this increase in your LDLs, increase in your triglycerides, that will result in cardiovascular disease. So you must know that, you must understand that, because here we are having the patient suffering from more heart pathologies. This is even worse if the patient is suffering from hypertension. Number 7, increase in potassium levels. Again, the kidney is unable to excrete potassium, therefore the potassium will begin to accumulate. Patient will suffer from hyperkalemia. Now, if the patient suffers from hyperkalemia, you'll also have to be aware that the patient may suffer from dysrhythmias. So you want to put this patient on telemetry. You want to report any chest pain to the physician immediately. Number 8, sodium. Now this may be decreased, and the reason it may be decreased be for 2 reasons. Again, remember that the kidney is unable to retain sodium. Also remember that if potassium goes up, sodium must go down. These have a inverse relationship. So again, if potassium goes up, sodium must go down. Again, your kidneys are unable to retain sodium, but also you're having an increase in fluid. You're having fluid accumulation, fluid overload. So that also will cause dilutional hyponatremia. Now, if the patient is suffering from dilutional hyponatremia, you have to worry about seizures. You have to worry about cerebral edema, headaches, altered mental status. Now, along with this increase in fluid, you have to worry about increases in their blood pressure. Again, peripheral edema, heart failure. Again, we want to restrict sodium intake. You may be wondering why. If their sodium levels are low, why wouldn't we give them sodium? Increase their salt intake? That's a very good question. Well, here we have fluid accumulation. Again, we have no urine production, so you're retaining all that fluid. So if you were to give large amounts of sodium to this patient, what you would actually do is you would increase their blood pressure. If that patient is already suffering from hypertension, if that patient is suffering from cardiovascular disease due to these triglyceride levels being increased, you give them large amounts of sodium, you're only going to make that blood pressure go up even higher, putting more of a demand on the heart. So that could be a problem. So therefore, again, you always watch their sodium intake. The amount of sodium that the patient may consume will be dependent upon what the doctor orders. Number 9, patient will suffer from increased levels of magnesium or hypermagnesemia. Again, this is due to the kidney's inability to excrete magnesium. So for these patients, you always want to monitor for absent reflexes. You want to monitor for changes in their mental status, for hypotension, for respiratory failure, for dysrhythmias. So we have multiple things causing mental changes. One, we talked about hyponatremia. If you have cerebral edema, that's going to lead to altered mental status. If you have increased BUN, that is also going to that will also lead to altered mental status. Dysrhythmias, so we have hyperkalemia causing dysrhythmias, and now here we also have hypermagnesemia causing dysrhythmia. So these patients, again, you want to place them on telemetry right away. Number 10, we worry about metabolic acidosis. Again, your kidneys are unable to excrete those waste products, so they just begin to accumulate in your body. The other thing is you have decreased bicarb levels. So again, this will result in a more acidotic state, in metabolic acidosis. Also, there will be an accumulation in the ammonia levels. Number 11, anemia. So how do we get with anemia? Well, let's take a step back. Remember that your kidneys produce something called erythropoietin. Now, erythropoietin is going to go to your long bones, to your bone marrow. It's going to stimulate red blood cell production, RBC production. Well, if you have no erythropoietin to cause that, you will have no red blood cells produced, and the patient will suffer from anemia. Therefore, these patients, we'll talk about this in our interventions, they may get something like Epigen, Procrit. They may also require iron supplements. Okay. Remember, hemoglobin and red blood cells, well, part of that needs iron. So again, you will give patients iron supplements. Now, if you're going to be getting iron supplements, you must inform your patient that iron supplements may cause constipation. So patients may need some type of stool softener. You will also give folic acid supplementation. Now, folic acid is needed for those red blood cells to mature. Also, remember that folic acid, if the patient is going to receive dialysis, during dialysis, folic acid will be removed. So again, the patient will need folic acid supplementation. Number 12, decreased platelet function or decreased platelet aggregation. Simply meaning patient will have a higher likelihood of bleeding, suffering from GI bleeds. Number 13, risk of infection goes up, or increased risk of infection. Now this is due to decreased immune system, from hyperglycemia, or frequent vascular access, especially if they're going to be having some dialysis, whether it's hemodialysis or peritoneal dialysis. All of that is going to increase the likelihood of them suffering from an infection. Number 14, heart disease or coronary artery disease. We just talked about this when we talked about how you're going to have increased triglyceride levels, those increased LDL levels. Also, this may be due to the hypertension that is already present. We also talked about how the patient is going to have dysrhythmias either due to hyperkalemia, hypermagnesemia, changes in their sodium levels. You may also have pericardial effusion. This is going to be due to that fluid accumulation in the lungs, a pleural edema, pleural effusion. that may end up with pericardial effusion. If that fluid accumulation in that pericardial gets bigger and bigger, end up with pericarditis, eventually with cardiac tamponade. So if you do not remember cardiac tamponade, go back to that lecture, check it out. Remember, you're going to have decreased cardiac output because, again, that fluid accumulation in that pericardial sac is not going to let that heart pump like it should. So again, you'll end up with heart failure, heart disease. Pulmonary edema, again, because you have that large amounts of fluid accumulation. So that will lead to pulmonary edema or pleural effusion. Uremic fetor, or urine odor in the breath. Again, you are unable to excrete all these waste products, so that is a reason for this. Number 17, depressed central nervous system. Again, this is due to an accumulation of waste products. So patients will suffer from lethargy, apathy, altered mental status. Now, if you're beginning to notice some altered mental status, this can be an indication that the patient needs dialysis therapy immediately. So you also have to watch out, monitor for seizures and coma. And these will be due to hyponatremia, due to that cerebral swelling. Peripheral neuropathy, especially if they are diabetic patients. They may also suffer from restless leg syndrome, paresthesia, burning sensation to the legs, to the feet, bilateral foot drop, loss of deep tendon reflexes, something known as asterixis. What asterixis is, muscle twitching and jerking. So if you see this on the Nclex exam, make sure you know what it is. Number 18, weakened bone or osteomalacia. And this has to do to a decrease in vitamin D, decreased ability to absorb calcium, and increased phosphate levels. So if you do not remember this, please go back and review the lectures on electrolytes. Go back to review the lecture on calcium and phosphate. Number 19, pruritus or itching. Again, this is due to an accumulation of waste products and something called uremic frost or urea crystallization on the skin. And this is due to those increase in BUN levels. Now, will you get uremic frost if you have a slightly elevated BUN level? No. BUN levels must be highly elevated. Okay. Let's get into some of our diagnostic studies. Number 1, dipstick testing or urine dipstick testing. What you're going to be looking for is proteinuria, protein in the urine. The big one that you must check for is microalbuminuria. Make sure you know that for the Nclex exam. Okay, these two things, you're going to do a dipstick testing of the urine. You're going to check for protein and albumin. So again, you will be checking for proteinuria or microalbuminuria, excuse me. Number 2, if you do a UA, you'll find RBCs, red blood cells, present in urine. That is not supposed to happen. You should not have any blood in your urine. So again, this is indicative of renal pathology. Also, you'll find WBCs, protein or proteinuria, and casts. We talked about this yesterday in our lecture on AKI, acute kidney injury. So if you see casts anywhere on your Nclex exam, that should let you to believe that this is asking a question on renal failure, renal pathology. Again, if you were to do something like a BMP, basic metabolic panel, you're going to check out, look at your creatinine and your BUN levels, or your BUN and creatinine levels. The main thing that you want to focus on, however, is your GFR, glomerular filtration rate. Something else that can be done is a renal biopsy. Let's focus on some interventions now. Number one, you want to control your potassium levels. And one of our concerns is hyperkalemia. Again, with hyperkalemia, you have to worry about dysrhythmias. So this is very, very important for you to always look at. You always want to check those lab values. Now, if it turns out that there is a large amount of potassium, you want to give something like IV glucose and insulin. Now, why? Again, we talked about this in a different lecture. If you were to give insulin, it's going to bring the potassium levels down. Well, you have to also give glucose, because if you give too much insulin, you always have to worry about, you have to be concerned with causing hypoglycemia. So if you're going to give insulin, you will also have to give glucose, again, to prevent that hypoglycemia. You can give something like IV calcium gluconate, or you can give Kayexalate. Now, if you're going to give Kayexalate, you have to tell your patient that this may cause diarrhea. Also, you will never give Kayexalate to a patient that is suffering from a paralytic ileus, or a patient who has hypoactive bowel sounds. So before you give Kayexalate, you want to make sure you listen to those bowel sounds. Are they hypoactive or not? You will ask your patient, have you had a bowel movement or not? Again, if they are hypoactive or if a paralytic ileus is suspected, you will not give Kayexalate. Make sure you know this for the Nclex exam. I've seen this on many questions, on many practice exams. So again, Kayexalate is given to control potassium levels. Number two, control blood pressure. So you want to control hypertension. So you need to educate your patient on weight loss, change in their diet, make sure they take their medication. Again, one of our concerns is cardiovascular disease. So again, we have to control hypertension. Number three, we want to decrease phosphate levels. And we talked about how the kidneys will be unable to retain calcium. So you will most likely suffer from hypocalcemia. Now again, calcium and phosphate have an inverse relationship. So if calcium goes up, phosphate levels will, if calcium goes down, if calcium levels go down, phosphate levels must come up. So what we want to do is we want to decrease these phosphate levels. We want to bring phosphate back down. So you will give something like Phos-Low. That's a pretty easy name to remember. Phosphate getting lower, you want to bring phosphate levels down. Phos-Low, Caltrate, or calcium carbonate. This will help bring those phosphate levels back down. Now the problem with calcium carbonate is this may also cause vascular calcification, which would only make heart disease even worse. So for those patients, you may give something like Phosrenal. So let's break it down. Phosphate, kidney, Phosrenal. Or Renagel. Again, these are all given to bring phosphate levels back down. Now these medications, you make sure that you give these medications with meals. It takes about an hour for these medications to actually take effect. So again, you always give these medications with meals. Number four, you will give vitamin D supplements. Now, we are giving vitamin D supplements. We're bringing phosphate levels down, and we're giving things like calcium carbonate. So what you always want to do is also you want to monitor calcium levels. Okay. Yes, we want to make those calcium levels go up, but we do not want them to go up too high. So please, guys, always look at your serum calcium levels and your serum phosphorus levels. Is your drug therapy having an effect? Is it having an effect that you're wanting, or that the patient is needing? Excuse me. Number 5, you will tell your patient to avoid Maalox Mylanta. Again, these have large amounts of aluminum products in them. So again, kidneys cannot excrete that. So again, you tell your patient to avoid Maalox and Mylanta. Number 6, you will give Epigen or Procrit. Again, this is to treat that anemia. Now this may take 2 to 3 weeks to see results. Now the target number that we want to get to is 10 to 12, their hemoglobin. Yes, we want to make sure that there is red blood cell production. Yes, we want to make sure that their hemoglobin numbers come up, but we don't want to make those numbers come up too high, because then we have to worry about very, very thick blood that could cause other complications. So again, the target is 10 to 12. Now again, with these patients that are receiving Epigen, Procrit, just like I mentioned before, you also want to give iron supplementation. You want to give folic acid supplementation. Now, very important for you to remember is you do not give these iron supplements with your Phos-Low or those other medications that I mentioned earlier. Okay, you will not give them at the same time. Number 7, if we're worried about our high blood pressure, again, we want to control it. So we may give something like the statins, Lipitor. Number 7, our statins. We want to bring those LDL levels down. We want to prevent heart disease. So again, you give Lipitor. You give something like gemfibrozol, Lopid. Lopid will help bring those triglyceride levels down. Okay, so the statins or something like Lopid to help prevent heart disease. Number 8, you will limit fluid intake. So you want to make sure you tell your patient not to gain any more than 1 to 3 kilograms of weight between dialysis treatments. Why? Well, we have no urine production, so all that fluid is going to accumulate. So again, fluid may be limited. Again, you want to tell your patient to not gain more than 1 to 3 kilograms of weight between dialysis treatments. Number 9, you want to avoid high sodium intake. Again, if you have increased sodium intake, you worry about high blood pressure. So you want to tell your patient to avoid things like soy sauce, pickled foods, salad dressing, canned soups. Number 10, you want to monitor phosphate intake. We talked about how low calcium levels will result in high phosphate levels. So again, you want to monitor what we eat. So you'll tell your patient to avoid milk products, ice cream, cheese, yogurt, pudding. Again, anything with milk in it, I want to tell them to watch out for. So make sure you know other milk products for your Nclex exam. These are the easy ones, so it's not very likely that your Nclex exam is going to give you any of these selections. So please look at your books for that information. Number 11, you want to avoid antacids. And finally, number 12, you want to avoid things that contain any pseudoephedrine. You want to avoid decongestants, antihistamines. Again, pseudoephedrine is going to cause an increase in blood pressure.